So I'm going to go ahead and resume our program and introduce our next distinguished speaker, Jamelia Hand. Jamelia is the owner and principal consultant of Vantage Clinical Consulting, LLC, where she provides strategic direction and training to healthcare organizations on opioids. She is a professor, author, and treatment advocate for addiction and recovery issues. Ms. Hand serves as a board member on the Illinois Certification Board and NAADAC and is the president of the Governor State University Addiction Studies Alumni Club. Recently, she received an award from the Illinois House of Representatives for her advocacy in opioid overdose. Please join me in welcoming Jamelia Hand to the stage.
So this wasn't set up for short people. Well, first and foremost, good afternoon to all of you. Is it still morning? Okay, listen, hey, this is what we do. We change. All right. So before I get started, it really is an honor to be here. I'm not sure how distinguished I am, but I appreciate the compliment. I'll certainly try to live up to your expectations of a distinguished professional, but please forgive me in advance if I don't. Right? I'd like to thank the University of Chicago, the SHARE Network, the Illinois Coalition on Substance Use and Aging. I think you guys are doing a fantastic job with bringing services and workshops to the community. We need as much of this as possible on a regular basis. So before we get started, I just want to share a little story with you guys. So the little person on the right is who? Does she look familiar at all? That's me. Yes, that is me. That's me at the tender age of maybe about 6 years old. So I don't know about you guys, but when I was 6 years old on a sunny Saturday morning, I would get up and I'd do what? Clean up. There we go. Absolutely. So every Saturday morning, like many of you, I'd get up, I'd, cut the television on. Tom and Jerry was my thing at the time. I'd cut on the cartoons and I'd do what else? Okay, so presentation is over. You guys get it. Exactly. I get up, I cut the television on, I cut on the Tom and Jerry cartoons, I get a big bowl of Captain Crunch, absolutely my favorite cereal, and my Ronald McDonald bowl, right? I pour it, of course it was a big bowl because I plan to eat the whole box because I could do that at 6. So one Saturday morning, like every other Saturday morning, that's what I did. And the kitchen window was always open. And I grew up on 89th and Parnell, south side of Chicago, right? So you could hear all of the activity outside. So normally on Saturday mornings, I'd get up, I'd, sit down in front of the TV. One morning in particular, I heard a woman who is my neighbor, Miss Oates. She would call for me every Saturday morning. Sometimes I get to watch my cartoons, other times I wouldn't. But Miss Oates would get up and she would call me, and she called me Toy Baby. My nickname is Toya, that's what friends and family call me. And she would say, Toy Baby. She would come to her back gate and she would stand at that gate and she would call me for as long as it took to get my attention so that I could come over. And the reason why she would call me is because I had a job. Every Saturday morning, I would go to her house and I would thread her needles. Every Saturday morning. So she would sew for her family, she sewed for the community. She was just a pillar, and we adored her, and we took care of her in the community. So my job was a really important one, right? So I heard her call for me, Toy Baby, Toy Baby. So luckily I was able to get through a couple of bites of Captain Crunch. I put on my shoes. I left out the back door, told my mom I was leaving to go visit Miss Oates. And I mean, I leapt over that grass like Laura Wilder on Little House of the Prairie. I mean, I was so excited because every time I went to Miss Oates' house, she would give me a sense of purpose. Her vision was failing, and so my job was really important. She couldn't do her job without me doing my job. And while I was doing my job, she would sing to me, she would tell me stories, and at the conclusion of my job, she would give me a couple of coins, some candy. You know, she would always give me a treat at the end. So on this one day in particular, at the end of threading about 200 needles, this was a big job on this day, but I took it seriously. She stood up and she looked down at me, I mean, directly in my eyes, and she said, "Toy baby, you are the best needle threader ever." And I was so proud. So I did my, Laura Ingalls Wilder, whatever her name was. I ran across that backyard again. I burst through the kitchen door and I started to holler for my mom. "Mom, come down the stairs." And she came down the stairs. She was, "What? What is it? What's going on?" I said, "Mom, I know what I want to be when I grow up." And she said, "What? What do you want to be?" I said, "I want to be a needle threader." So I tell you guys that story to say to you that everybody needs a cheerleader. And I want to sincerely say thank you so much to each and every one of you in here because you're somebody's cheerleader. And it just so happens that for most of my young life, Miss Oates was my cheerleader. And she made me love seniors. She made me adore seniors. I couldn't wait to go out and do good in my community and help the seniors. And I was that kid on the block. I went to block club meetings as though I was one of the girls, or the guys that came to the block club meetings. I was making decisions. How many of you at, preschool age, how many of you know who Luke and Laura was? Okay, I should see more hands than that. Okay, so you were not raised with a senior. If you don't know who Luke and Laura was, and you don't know if Erica and Dimitri were going to make it, and that was important to you as a preschooler, it was important to me whether Luke and Laura were going to make it. I was 4 years old, and that was a big deal to me, just so you guys know. So again, I want to thank all of you for being here with us today. So what are we going to discuss? We're going to discuss clinical considerations. Most of us are helping healthcare professionals, and there are a lot of things that we have to consider when working with aging adults. What would you say is one of the first things we need to consider? Don't all answer at once. One of the first things that we need to consider when working with aging adults. Be gentle. Okay, that's important. Mental status, very good. Social support, oh my God, that's so important. What else? Absolutely. And if you guys can't hear in the back, just let me know, and that way I'll repeat what anyone says up front because this is likely to be interactive. Otherwise, I'm gonna go crazy. I like to talk to people. So with that, we're going to talk about some of the clinical things that we can consider when working with aging adults. Dr. Cody mentioned earlier that there were about I believe it was 2.1 million people who suffer from opioid use disorder. And based on his numbers, about 10% of those people actually get help. I'm assuming that for an aging adult, even less than that will seek or obtain help. So why is that? Why is that? What's that? Stigma, absolutely. Transportation, and Dr. Malik mentioned several of those things. There are certain barriers that they have simply because they're an aging adult. What about apathetic family. Yeah. What about, and this happens, is prevalent in some cultures, but what about, she is old and she deserves to drink a half a box of wine if she feels like it. Okay? I actually heard that in my house, but I won't go into that story. But substance use disorder in older adults is expected to double. So what do we have to look forward to? Our clients are not getting any younger. And if we don't get a hold of this, then what can we expect? Even now, I believe Dr. Cody mentioned that we have seniors who are taking care of children who have had to arrive at the foster care system because their parents suffer from substance use or opioid use disorders. So now we have seniors who are taking care of children, and they may very well suffer from a substance use or alcohol use disorder themselves. So we have a lot to consider. So what do we know? Dr. Malik mentioned that baby boomers are the fastest growing sector of the population, and they use more than one third of prescribed medications. How easy is it for a senior to get a prescription for an opioid? Pretty easy? Pretty easy? Absolutely. I went to the doctor with my grandmother, who has always lived a very, she's going to live until she's 150. I believe that wholeheartedly. She walks 5 miles a day. She's been a vegetarian most of my life. She wakes up in the morning and she meditates. She does everything right. And it wasn't until recently that she started having medical issues. I went to the doctor with her one time. She lives in Florida right now. And I had to drive her to Jacksonville to the Mayo Clinic. They gave her 10 different prescriptions. 10 prescriptions. She has never taken a medication in her life, but now she has to take 10 prescriptions. 2 of them were opioids. Another story. In addition to elders having, transportation issues, the fact that they're getting older, they're being prescribed more medications. As we get older, we just end up taking more medications in general. But there's also increased emergency department visits. More often than not, seniors have no problem going to the emergency department. I had another grandmother who was a little bit of a hypochondriac growing up. And I can remember one time I said, Grandma, what's wrong with you today? Because every day it was a different illness. And she said, babe, I think I have intestinitis, gastritis. And I said, well, what is that? What is that? I have no idea what it is, but according to her, intestinitis, gastritis, and maybe the physicians can help me out with what that is. But according to her, she had it. Now, I can only imagine if WebMD was available. Oh my God, that would be terrible. Another thing that we know about seniors and just getting older in general is they suffer from a lot of grief. They're seeing, friends pass away frequently. Some of them have lost, family prematurely. And depending on the community that they live in, trauma could be a daily part of their walk to the store. I can remember the community that I grew up in. And this is the interesting thing about a community, because once you live in it and it's normal, you don't realize that things are abnormal. So one time I was walking to school, and like many of the houses on the south side of Chicago, you have, the houses, and then you have the alley dividing the blocks, and then on the other side, you have the houses. I would often cut through a neighbor's yard to get to the other block so that I could walk to school. One morning, I could not have been more than 10 years old. I was cutting through, to a house on the next block, and I saw a neighbor shoot someone I don't know who the other person was, but I saw him shoot another person because I was in between the homes. So I never said anything. I never told anybody. I went back towards my house. I didn't go home. I just went to the next block and then walked to school that way. So after school, I'd stayed a little bit late to go to a cheerleading, practice. And it was a little bit before dusk before I started walking home. So I walked the way I normally walked, and I came down the block where I witnessed the shooting that morning, and I ran into the guy that shot someone else on the block. And he said, "Toy, where you going?" I said, I'm going home. I didn't say I saw you shoot someone earlier. I just said, I'm going home. And he said, "Well, baby, it's dangerous out here. Your daddy don't want you walking home by yourself." And he hand-delivered me to my home. Walked me to my home because it was dangerous out there. So the last thing I want to talk about a little bit are, again, the cultural considerations. In the Black family, again, no matter how old you are, the elders in the house, they have what? Rank. Whether they are right or wrong, they have rank, right? They outrank you. It does not matter how irrational they are. It does not matter what they do. They can smoke 17 packs of cigarettes in one sitting, but it doesn't matter because they outrank you. And you have to listen to them and do what they say. So one of the things that we need to consider as treatment professionals before treatment starts is, first and foremost, what is the environment like? What is the environment like? When someone comes into your environment, what do they see? What do they think? How do they feel? And how do you know that your environment is supportive of their recovery? That was a question. How do you know? How do you approach them? Based on your approach, absolutely. If any of you have called to make a medical appointment recently, what was the first thing that happened when you called? You get a recording. If you're lucky, you get a live person. But if you do get a live person, odds are you're put on hold immediately. Now, I don't know about you, but the seniors in my life, they don't wait for anything. They like for everything to happen fairly quickly. So when you call a healthcare professional, organization, treatment center, you really want to ensure that you can answer those calls quickly. Another thing is the type of therapeutic interventions you provide. One thing I've seen firsthand, even when I was working with clients, is that the group therapy, we would always group everyone together, no matter how old they were. Now think about it. Someone who, an aging individual who suffers from substance use disorder, to come into a group with millennials and have to disclose the deepest, darkest things that they're struggling with. How much are they going to get out of that intervention? Very little, right? We need to be mindful of that. They've also grown up during a time where substance use disorder and mental health treatment is considered taboo. One thing I heard a great deal growing up in my household is, we don't go to no head doctor. What's a head doctor? We don't do that. So treatment may have been discouraged. We didn't hear a lot about that. And I grew up with several people within the household who suffered from addiction, including my father. What about access? How many treatment, I believe that most of them are, have wheelchair accessibility, but how many of them have resources for those that might be vision or hearing impaired? We just simply don't have that. What about the materials that we pass out? Is the font or the print on the material big enough for them to actually read it? Do we have age-specific brochures? Those are things that we need to consider. We also need to be cognizant of whether or not they have medical issues or other comorbidities. Trauma is a big deal. We need to ensure that we have resources to support them in healing from grief and trauma. And feelings of isolation. I remember an older gentleman, this was very early in my career, if I can call it that. I'm still a baby in the field. It's only been 20 years. But there was an older gentleman who was on my caseload, and this gentleman suffered from heroin addiction, is what they called it at the time, but now we know better. He suffered from opioid use disorder, and he was having a very hard time. He lived in a senior building. He still had a very good pension. He had a vehicle. He was pretty hot in his senior building. He had a lot of resources and he had a lot of company. As a matter of fact, 2 very nice young ladies brought him to treatment. Very nice young ladies. Very nice. Okay. So when he was placed under my caseload, and at the time I was in my early 20s, and this gentleman was in his 60s, I could relate more in some cases to the young ladies, in some cases, age only, as I could to him. But one of the things that I knew I needed to do was I needed to connect with him. So the first thing I did is I went to an elder on staff for the treatment agency that I worked for, and I pulled him in, and I used him to help me to build rapport with the client. And one of the things that I learned over time is that he struggled with his family. He had 2 daughters who had not come to see him for almost 2 years. And the reason why they didn't come and see him is because he had lost his wife, and he still lived as though she was living. He would set the table for dinner. He'd lay out her clothes, and he missed her. He missed her terribly. So with that, I had to understand what he was dealing with, and what we end up finding out is that his primary diagnosis was grief. And the young lady friends that he had, the only reason why he was getting high is so that he could have company. So once we were able to get control of the grief, guess what happened? Absolutely. We were able to get a hold of the opiate use disorder, and he left there with a solid recovery plan. So in going back to environment, what do we need to offer a supportive treatment environment? We heard the doctors mention that we need to treat the whole person. It's really important. We need to treat the whole person, and we need to have a treatment team. And there are so many people on the treatment team. I believe Dr. Cody had a slide that referenced all of the people who can positively impact the recovery process with the client. We have the patient, and I like to look at this like links on a chain, right? And every link represents a person who can make a difference. So we have the patient, we have the physician, we have the nurse, the family, the case manager, the pharmacist. My God, pharmacists have really joined the fight in opiate addiction, wouldn't you guys say? Yes, pharmacists have become really instrumental. And as treatment professionals and counselors, let me ask you guys, how many of you go to pharmacies regularly? Okay. So we all go to pharmacies, whether we stop in and, get something to drink or pick up a prescription. But all of us at some point go into a pharmacy, maybe once a month. How many of you have actually gone back to the pharmacy and just took a moment to ask a few questions about what was happening in your community? How many of you have gone to your pharmacist and said to them, this opiate epidemic has really gotten bad, and I just want to know, what are you guys doing to help address that? Okay, we have one person. Absolutely. It's really important for you guys to step outside of your offices and go and talk to the people in your community who have insight into what's happening. And pharmacists know it all. Most of them have a box where they have names in that box of physicians that they're concerned about. As counselors, what's stopping you from going in to educate them? What's stopping you from going in and saying, hey, pharmacists, are there any physicians in the area that you think I should go and talk to and help them with addiction issues? I'm an addiction counselor or a psychologist. You know, who should I be talking to? They're happy to give you that information. In addition to that, we also need a welcoming physical environment. We talked about that earlier when we mentioned, you know, wheelchair accessibility, making certain that you have resources that are visually appealing and that you have things to supplement your treatment for vision and hearing. I mean, yes, vision and hearing deficits. All right, let's talk about, in my opinion, one of the most important people on the treatment team, and that's the receptionist. Why is a receptionist important? First impression, absolutely. So one of the things that, and I know you guys have your own way of doing things, and you certainly don't have to do them the way that I did them, but one of the things, I would get really excited when I had a new client. I mean, really excited. Like, I wanted to meet them in the lobby. I don't care if I was working on case notes. I don't care if I had a phone call. I would get off the phone at the time of their appointment. I would go down to the lobby. I would look them in their eyes and say, I'm so happy you came here today. I don't know what else you had to do. I don't know what else you wanted to do, but I'm so excited about you being here. And that set the tone. But in some cases, people are going into treatment in healthcare centers, and the receptionist doesn't even look up. He or she might be on the telephone, and you know, not this. I mean, I would take this over ignoring me as a patient. You know, just give me a minute. You know, just that little thing can help someone to feel better in your presence. Oftentimes, the receptionist is young, inexperienced, and the least paid person on the roster. But they're in a perfect position to make a difference. Perfect position, right? So we have to train them. What's stopping any of you, once you go back to your offices or organizations, pulling the receptionist aside and say, hey, when people are sitting in a waiting room, these are some of the signs and symptoms you can look for regarding substance use disorder or opiate use disorder. What's preventing you from training a receptionist on identifying whether someone in the lobby is in withdrawal? Do you want them to get sick in your lobby? Yeah? That's always fun, right? Makes everyone happy when someone gets sick in the lobby. And that's something that we can prevent. A well-trained receptionist, especially if they understand about opioid use disorder because you guys took the time to train them, they will know. They will come back to you and say, well, you know what? There are 2 patients in the waiting room. They appear to have, restless legs. A couple of others were, yawning, or there was someone who is experiencing back pain because they shared that with me. His eyes were watering. There was someone else that threw up. Someone else that had to go to the bathroom because they had diarrhea. Like, those are things that you can share with them, and you can give them a checklist of things to look for, and they can share with you where the patient is in their stage of withdrawal. And that way you can get a patient back quicker. No one wants to be sick in a lobby in front of a whole bunch of strangers. The receptionist, again, is a great place to start in setting the tone, and it's a great opportunity to begin a strength-based intake process. Meet the patient at the door. Forgive me, you guys. Meet the patient at the door, walk them to the office, and submit. Why is it important to submit to an aging client? Respect, absolutely. How often will they disclose to you if they don't feel like you respect them? It's not going to happen. So during the intake and assessment process, you want to be grateful. You want to again thank them for coming and being with you, for sharing information that they probably haven't shared with anybody else. How about an engaging opener? How many of you have something that you say when you open a discussion? Whether it's, again, thanking them for being with you or saying, you know what? Wow. Especially if you get the case notes early enough. You can look at the time where they were born and look up some wonderful things that happened during that time and say, hey, you know, you grew up during the time where jazz was really hot in Chicago. Tell me what that was like. You know, just a little bit of small talk. Let them share with you something that meant something to them growing up. Let them know you're listening. Or what about, can I offer you a snack? That goes a long way. How many of you have snacks? What? Okay, I wouldn't come and see you. If you don't have snacks, I'm not coming. That is a prerequisite. You have no idea what people took to get, what it took for them to come to you. Whether they had to take 3 buses, you know, a train, you just don't know. So we want to make sure that we have something to offer them. Plus, you don't go to anybody's house without taking something. You don't let people come to your house without giving them something. Now, how many people in here who are aging know that to be a fact? That's right. You have to be hospitable. What if we ask, what are your thoughts about being in treatment right now? Everybody doesn't want to be in treatment. They may have other plans. Ask them what they think about it and let them share that with you. It's important. What would they like to get from treatment today? And what do you feel comfortable in discussing right now? One of my first clients was a woman who was 60 years old, and she was just as gregarious as she wanted to be. I mean, she had to let everyone know she was in the building when she got there. We walked down the hallway to the office, and she just cracked me up the whole time. I thought we had a good thing going until we got in the office and we sat down. And I said, Miss Rose, what drugs are you taking? How are you taking these drugs? You know, what's your sexual history? Do you have a history of mental illness in your house? And she said, wait a second. You don't know me like that. You don't know me like that. And I didn't. I didn't know her like that. That was not the respectful approach. But unfortunately, that particular nuance, it wasn't something that I was taught in school, but I learned that lesson, and I never forgot it. I had to submit to her because she was the elder. No matter how much wrong she had done in her life, she was the elder, and I had to submit to that. So one of the ways that we submit is we first find out what their definition is of treatment. When's the last time you asked a client what their definition was of treatment? We throw out a lot of acronyms and phrases and things that are known to us and specific to us, but they don't know what that is. I once worked at a medical stabilization program. I saw an average of 200 to 300 patients per month who would come in acute intoxication or withdrawal. We put them on a 2 to 3 day methadone taper, and then we'd release them back into the community, right? During that time, I would ask them, what do you think treatment is? And do you think it works? I can remember one gentleman, he said, no, it doesn't work. I've been here 30 times, and I'm still not where I want to be. He thought medical stabilization was treatment. He didn't know any better, and no one had taken the time to explain it to him until that moment. It's important to let them know what they can expect from you, what your commitment is, and what they believe they need to have a successful experience with you. Recovery planning is about them. It's totally about them. It's not about us, it's about them. But how many times do we stray away from whatever paperwork needs to be done and just say, what are your thoughts on this? How do you feel about this? Let them define the treatment process. We need to respect their approach to problem solving. How many of us go to church to get fixed? We take it to God. That's what we did in my family. Again, we didn't go and see no head doctor. We took it to church. God will remove this from me. This is the devil. That's what I learned in my household. That's what the elders taught me. So that was my understanding. Obviously, it's important to be sensitive to generational issues. If you have the capacity to offer more individual therapeutic sessions, then we should try to do that. Group therapy, remember that when combined with the younger generation, they could be uncomfortable and they'll go with the flow. They won't open up. They'll sit in groups, but they won't try to work on anything that's meaningful. So try to offer individual sessions, as many as possible. Speak louder and slower if they need that, and you'll know if they need that because they'll have questions. They'll tell you that they have a challenge hearing. Don't assume it, and don't just start speaking loudly and slowly to your aging patients. Again, listen carefully, and as Dr. Malik mentioned, educate them on overdose. And I'm so happy to hear that's what your organization is doing. We really need to do more of that. So how many of us are empowering our patients through resources? How many of us have a resource Bible? Okay, that's a lot of you, a resource Bible. Everyone in here is a resource. So today, use this as an opportunity to connect with each other and find out what the other person is doing so that we can combine our resources and make more of a difference. We need to know about supportive housing, educational resources, what community workshops are available. And you guys, if you can get outside of your offices, go and offer workshops to your community. What's wrong with starting in your church? Every year I do what I call training tithes, where I offer 10% of my time to my community. I usually go to a church in my community, but last week I went to Oak Street Health, and I taught a group of seniors medication storage, safeguarding, and disposal. And it was so much fun. Consider doing that. Know who your medication-assisted treatment providers are and those that may be aging friendly. Go to the office and see. Take a look around the waiting room. Make sure that it's an appropriate environment for a referral. They don't mind if you stop by. When they offer a high-quality service, they want to partner with you. They don't mind you stopping by, and they're willing to share with you what they're doing to help people recover. Consider alternative therapies. Again, know what detox versus medical stabilization, and which organizations are aging friendly. Know about the social resources in your community. Any others? So I'll conclude. It's really important that we believe that people can get better, and we tell them. It's really important to believe that people can get better and share that with them. We need to tell them from the first moment that they sit down with us, I believe you can get better, and I want to help you to accomplish that if you let me. No matter how bad the circumstances are, aging clients have a lot to offer the treatment experience. It's light behind the darkness, hope behind despair, gleam behind the misery, look for it and nurture it. Who's familiar with the old adage of AA? Don't give up before the miracle happens. How many of us have heard that? I will wrap up. Thank you.